welcome to the deep dive. Today we're tackling a surprisingly common issue, varicose veins.
Yeah, those dilated subcutaneous veins in your legs.
Exactly. And we're going to unpack the surgical ways we deal with them, drawing on insights from Rutherford's vascular surgery and endovascular therapy.
It's pretty staggering when you think about it. Venous disease, including varicose veins, is actually more common in the U.S. than coronary artery disease, peripheral arterial disease, heart failure, and stroke combined.
Wow. Combined. That really puts it into perspective. It's not just cosmetic then.
Not at all. It's a significant burden, really, on the healthcare system and, people's lives.
Absolutely. And it's kind of fascinating that while diagnostics improved a lot in the late 20th century, the surgical treatments themselves, well, they didn't change hugely until more recently.
Right. The 21st century brought this surge of new interest and new techniques.
That real shift.
Definitely. We've seen endovenous ablation, EVA, and sclerotherapy really take the lead for many superficial vein issues.
But surgery still has its place.
Oh, absolutely. Especially traditional open techniques. They're still vital when done right, particularly for the small saphenous vein, the SSV, and other veins sort of tucked away behind the knee in the popliteal fossa.
Okay, so our mission today is to really get into the current surgical options, why they're still used, and, what makes them relevant today.
This is good.
All right, let's unpack this. When we say varicose veins, what exactly are we talking about technically?
Basically, they're defined as those subcutaneous veins in your legs that measure 3 millimeters or wider when you're standing up.
3 millimeters, okay.
And they can affect the main superficial veins. That's the great saphenous vein, the GSV running up the inner leg, and the small saphenous vein, SSV, on the back of the calf, or their branches.
And what's usually the root cause? Is it just bad luck or?
Well, mostly we think of them as a primary issue, meaning it starts in the vein itself.
Oh, okay.
The current thinking points towards a weakening in the actual vein wall. Could be genetic factors, maybe biochemical stuff we don't fully grasp yet.
And the valves. I thought it was all about faulty valves.
The valves are almost always involved, yeah. They might kick off the dilation or certainly make it worse once it starts, but the wall weakness seems key.
I see.
And sometimes, though less often, they can be secondary, maybe after a blood clot in the deep veins, for instance.
So once you have them, they generally stick around or get worse.
Unfortunately, yeah. They tend to progress over time. Sometimes they might improve a bit after pregnancy, but generally the trend is worsening.
Which leads to symptoms, I imagine.
Right. That's what usually brings people in. Like pain, swelling, especially after standing for a while, that heavy, tired feeling in the legs.
Ah.
And then you can get complications like superficial clots, bleeding from those thin-walled veins, skin issues like eczema, and even in severe cases, skin ulcers.
Okay, yeah. That explains why treatment is needed. So what are the options on the table?
It's really a spectrum, depending on the person. It ranges from, doing nothing actively, just monitoring, to conservative things like compression stockings, maybe some medications. Then you get into sclerotherapy, the injections, and the various surgical approaches, both open and endovascular.
You mentioned chronic venous insufficiency, CVI. How does that fit in?
CVI is super common, affects maybe a third of adults in Western countries. It's basically when the veins aren't doing their job getting blood back up efficiently.
And varicose veins are a sign of that?
A very common sign, yes. Luckily, only a small fraction of people with CVI get the really severe stuff like venous ulcers, but it's still significant, up to 4% of folks over 65.
So things like compression stockings and putting your feet up, they help with symptoms, but they don't fix the underlying vein problem.
Exactly. They provide relief, manage symptoms, but the faulty vein is still there. If you stop the compression, symptoms often come back. And ulcers, they have a high chance of recurring with just conservative care. It's like patching a leak temporarily.
Right, you need to fix a pipe.
Pretty much. So the goal of the more invasive treatments is to deal with those veins where blood is flowing the wrong way. That's reflux.
How do they do that?
The aim is to either remove the problem vein, close it off, ablate it, or tie it off, which we call ligation.
And what are the main surgical tools in the toolbox right now?
Okay, so you've got high ligation, tying the vein off near the depth system, ligation and stripping, or LNS, tying it off and pulling it out. Then EVA, endovenous ablation using heat or chemicals inside the vein,
Yeah.
sclerotherapy, those injections mainly for smaller veins,
Hmm.
chemical ablation, sometimes called glue, and ambulatory phlebectomy, removing surface veins through tiny cuts.
Wow, quite a range.
Yeah, and ideally a vascular surgeon should be comfortable with all of these to really tailor the treatment. It's definitely not one size fits all.
That makes sense.
Yeah.
What about getting these treatments approved? Insurance hurdles.
Oh, yeah. Insurance providers usually want to see a few things first for certain levels of varicose veins like CEA PC2 to C4 classifications.
Huh.
They generally reflect visible veins, swelling, skin changes, but not ulcers yet. Insurers often want proof you've tried conservative therapy, like compression stockings, for maybe 6 weeks to 6 months to see if symptoms get better.
And if you have ulcers, like C6,
Then stronger compression is usually the first recommendation, but often intervention is covered more readily.
got it. So before any surgery, what's the assessment process like?
It's really thorough. You need to look at the patient's overall health, obviously, but also the specific vein anatomy using ultrasound. That's critical.
Why the overall health focus?
Because vein surgery is often elective, right? Symptoms can often be managed. So medical factors are key. Healthier patients with a longer life expectancy generally do better long-term.
Right.
Though the less invasive EVA techniques have broadened the pool a bit, we see people over 70 being treated now who might not have been candidates for open surgery before, but patients with really serious other health problems are usually managed non-surgically.
And you mentioned guidelines tend to favor the less invasive stuff now.
Yeah, generally. For issues with the main saphenous veins, guidelines often recommend EVA over open surgery because recovery tends to be faster, less pain, fewer issues usually.
Okay, that sets the stage really well. Let's get into the anatomy. You said knowing the leg's vein system is crucial.
Right.
Why is that so fundamental?
Well, think about it. The leg veins are fighting gravity constantly to get blood back to the heart. It's a tough job. It relies on two main things: the calf muscles squeezing blood upwards when you walk the muscle pump, and these tiny one-way valves inside the veins.
Little gates you mentioned.
Exactly. They open for flow towards the heart, then snap shut to stop blood falling back down when the muscles relax. Problems start when these valves get damaged, maybe after a clot, or if they're faulty from birth, or just wear out.
And knowing where the faulty valve or vein segment is
Absolutely key to picking the right treatment. You wouldn't fix a leak in your house without knowing which pipe is broken. Right, same idea.
Makes sense. Let's zoom in on the big players. The Great Saphenous Vein, GSV. Tell us about that one.
Okay, so the GSV. It starts down near your inner ankle bone, then travels up the inside of the calf and the inside of the thigh.
All the way up.
Pretty much, yeah, towards the groin. Anatomy varies, though. In the calf, it's usually a single vein, maybe 2/3 of the time, but sometimes it's doubled.
And in the thigh.
Usually a single main trunk there, too. But again, you see variations, branches, sometimes completely doubled. Plus, there are accessory veins, sort of parallel tracks, an anterior and a posterior one.
And you mentioned different types.
Yeah.
Based on how it sits in the tissue.
Right. Types I, H, and S. It relates to this fascial envelope, a layer of tissue around it. Knowing the type helps surgeons plan, like where to make cuts or how to approach the vein during stripping, for example.
Fascinating detail. What about the small saphenous vein, the SSV? Back of the calf.
Yep, back of the calf. And where it connects into the deep system, into the popliteal vein behind the knee, that's really variable. Well, in about 1/3 of people, it actually joins the deep system above the knee crease. A really low connection way down the calf is pretty rare, less than 10%.
So ultrasound is vital there too.
Absolutely critical. You need to pinpoint that junction precisely for safe and effective surgery behind the knee.
And what about the gastrocnemius veins? From the calf muscles.
Yeah, they drain the big calf muscles, the gastrocs. They can plug directly into the popliteal vein, or sometimes they join the SSV first.
Why does that matter?
Because if those gastrocnemius veins are leaky, incompetent, and you only treat the SSV below where they join, you haven't solved the problem. The reflux will just continue down the SSV from those muscle veins. We see that quite a bit in people with SSV issues.
Interconnected problems.
Yeah.
What about the inner saphenous vein? Used to be called Giacomini.
Right. That one runs up the back, inner part of the thigh, usually starts from the SSV and tends to connect higher up, often into the GSV system rather than directly into a deep vein.
Is it often leaky?
Less often than the GSV or SSV on its own. But if the GSV or SSV are incompetent, then the intersaphenous vein is much more likely to have reflux too. It can become a pathway for blood to flow backwards between the two main systems.
Okay. Now that area behind the knee, the popliteal fossa, Sounds tricky for surgery. Nerves and things.
Extremely tricky. It's crowded back there. You've got major nerves and vessels packed close together. The tibial nerve is right there. Sometimes the sciatic nerve sits lower than usual, very close to the SSV junction.
And they can look like tendons.
They can, yeah. Which means you need to be really careful to identify them properly, avoid injury. And then there's the sural nerve, a sensory nerve, which often runs right alongside or even wrapped around the SSV, especially lower down. It's very easily damaged during SSV surgery.
Leading to numbness.
Numbness, tingling, sometimes pain on the side of the foot. So yeah, meticulous dissection is crucial back there.
Sounds like it. And briefly, perforating veins. You mentioned them connecting deep and superficial.
Exactly. They perforate the fascia between the superficial and deep systems. Normally, flow is one way, superficial to deep. But if their valves fail, they become incompetent, and blood can flow backwards, from deep to superficial, contributing to varicose veins and skin problems.
Right, adding to the pressure.
Precisely.
Okay, so armed with all that anatomy, let's talk surgery. You said it's individualized?
Absolutely. No cookie-cutter approach. You tailor it based on that detailed preoperative evaluation, which veins are bad, where the reflux is coming from.
And often involves mixing techniques.
Very often, yeah. A surgeon might do a high ligation, maybe some stripping of the main trunk, and then phlebectomy for the branches, maybe even ligate some perforators all in the same procedure potentially, using the right tool for each part of the problem.
Where does this usually happen? Hospital? Office? Anesthesia?
It really varies. More complex stuff, maybe longer procedures, anxious patients, or those with other health issues, often better in a hospital with general or regional anesthesia.
The simpler cases.
Many can be done very safely in an office setting using local anesthesia, especially tumescent local anesthesia, maybe with a little sedation. Depends on the procedure, surgeon setup, patient preference.
You mentioned marking veins beforehand while standing. Why is that so vital?
Oh, absolutely critical, especially for phlebectomy, removing those surface branches or targeting perforators directly.
Because they disappear when you lie down.
Pretty much. Once the leg is elevated and the veins drain, those bulging varicosities can flatten out and become really hard to see or even feel. Marking them while they're full ensures you know exactly where to make those tiny incisions.
Makes perfect sense. Okay, let's get specific. High ligation of the great saphenous vein. How's that done?
Typically through a small diagonal cut right in the groin crease. Ultrasound guidance helps pinpoint the junction, the saphenofemoral junction, or SFJ, so the incision can be kept small. The surgeon identifies the main GSV trunk and carefully ties off and divides all the little tributaries, the branches joining it right near the top. You have to see that junction with the deep femoral vein very clearly to avoid injuring it, or the femoral artery.
How many tributaries are usually there?
Usually around 6 main ones, but it varies.
Yeah.
You need to check the femoral vein above and below the junction too, make sure nothing else is joining directly.
And then tie off the main GSV.
Right. Tie it off very close to the femoral vein, usually double ligated, maybe with a suture ligature for extra security. Crucially, you don't want to narrow the femoral vein, and you want to avoid leaving a long stump of the GSV behind.
Why no long stump?
A risk of clot forming in it, potentially extending into the deep vein. Sometimes they even oversew the opening on the femoral vein side instead of just tying the GSV. And there's a technique to sort of tuck the cut end of the GSV inwards, potentially reducing regrowth of new vessels later.
Interesting. And what about ligating all those tributaries? Is that still standard?
It used to be. But now, some evidence suggests maybe only ligating the ones that are actually refluxing and leaving the normal ones alone might be better long term. Still debated, though.
Okay. Now, GSV stripping. How's that different? It's done with the ligation, right?
Often, yes. Ligation and stripping, LNS. Stripping means physically removing a segment of the vein. It's a core part of traditional varicose vein surgery. Studies show recurrence is lower when you add stripping to the ligation.
Do you always strip the whole vein?
Not necessarily. Pre-operative ultrasound mapping is key here. You figure out how far down the reflux actually goes. Often, it's just the thigh segment of the GSV that's bad. If the below knee part looks okay and isn't causing issues, you might leave it.
Why leave it?
Well, in some anatomical types, that below knee segment might be underdeveloped or even provide important drainage. Removing it unnecessarily could worsen things or risk nerve injury. The saphenous nerve runs close by down there. Targeted stripping is often better.
You mentioned accessory veins. Need to deal with those too.
Definitely. If there's an incompetent accessory saphenous vein, it needs addressing during the first surgery. Missing those probably explains some historical stripping failures. Again, ultrasound mapping is essential now.
So how do you actually strip it after the ligation?
After the ligation, you make a small cut in the GSV and pass a stripper, a long flexible wire or plastic rod, down inside the vein, usually towards the knee.
Okay.
Then make a second small cut at the knee, find the stripper tip, and pull the stripper, with the vein attached, out. Passing it top down helps find the vein at the knee, keeps the lower incision small, and avoids accidentally pushing the stripper into the femoral vein via a perforator.
And you pull it out downwards or upwards?
Usually downward stripping is preferred, helps avulse tributaries, and may reduce nerve injury risk. You tie the stripper head to the top end of the vein, maybe attach a long suture to trail behind it. Then, after dealing with the lower end at the knee, you pull the stripper and vein back up towards the groin incision.
Is there another way? You mentioned turning it inside out?
Yeah, inversion stripping uses a special stripper, sometimes without a head. The vein gets inverted as it's pulled out, makes a smaller tunnel, maybe less trauma. Downside is it can tear more easily where branches come off, leading to incomplete removal.
So you always check the removed vein.
Always. Lay it out, measure it against what you plan to remove. If it tears, that trailing suture lets you go back in, maybe from the bottom up, to get the rest.
Stripping sounds like it could be pretty rough on the patient. Anything to make it easier.
Oh yeah, definitely. It used to have a bad reputation, but simple additions make a huge difference.
Like what?
Ultrasound guidance, for starters. Precise marking means smaller, targeted incisions. And tumescent anesthesia, that's been huge.
Remind me what that is.
Injecting large volumes of dilute local anesthetic with epinephrine and bicarb all around the vein in the thigh using ultrasound. It numbs brilliantly, often allowing office-based stripping.
And the epinephrine helps with bleeding.
Exactly, constricts vessels. Plus, the fluid volume compresses tissues, so less bleeding from torn tributaries, less bruising, less pain afterwards. Big improvement.
What else helps?
Minimizing blood left in the stripping tunnel. That can cause a painful cord, so strip last if doing other things. Wrap the leg tightly immediately after, lots of padding, good compression.
Elevation too?
Yep. Elevate the leg before and during stripping. Reduces bleeding. Post-op, walk soon, but avoid heavy exercise or prolonged standing initially. Most folks are up and about pretty quickly now, often outpatient or office-based.
Any need for tourniquets?
Rarely. Maybe for really massive varicose veins, like in Klippel-Trenaunay syndrome, just to control potential major bleeding during the dissection. Inflate it, do the work, deflate it.
Okay. Shifting focus to behind the knee, the small saphenous vein, and that popliteal fossa area, you said it's trickier.
Yeah, historically a bit overlooked and definitely more technically demanding. Fewer studies compared to the GSV. Fewer people have only SSV problems, sometimes need repositioning during surgery if doing both legs or GSV too. And then there's the nerve proximity issue.
The sural nerve, mainly.
Sural and tibial nerves, plus vessels. Higher risk of complications. But SSV reflex is definitely linked to problems, calf varicosities, especially recurrent ones, outer ankle ulcers, ulcer recurrence after perforator surgery. It's important.
Yet surgeons sometimes don't mark it precisely or expose the popliteal vein.
Surveys suggest that, yeah. While most use ultrasound pre-op, maybe only half mark the junction on the skin, and fewer routinely expose the popliteal vein itself, trying to avoid nerve injury or clots. But that makes it harder to spot and treat other leaky veins nearby, like those gastrocnemius veins.
Which can lead to treatment failure.
Exactly. If you ignore those other reflux sources, the problem persists. Open surgery is often better for these complex fossa issues than EVA or sclerotherapy, especially if they drain right into the popliteal vein.
So what's the typical open technique for the SSV?
Patient is positioned face down, carefully padded, knee slightly bent to relapse things. Ultrasound marking guides a small horizontal skin cut just below the junction.
Okay.
Find the SSV, trace it down a bit. Might need Doppler to confirm it's the vein, not an artery, due to high pressure. Divide it between clamps. Dissect carefully around it, gently separating any nerves, usually the sural nerve.
Gently is the key word, I imagine.
Very gentle traction. Visualize the junction with the popliteal vein. Tie off the SSV end. If it joins a gastrocnemius or intersaphenous vein first, forming a common trunk, you ligate that trunk above the popliteal vein connection.
And if those other veins are leaky too?
If ultrasound showed reflux in individual gastrocnemius or other fossa veins, you might extend the incision and ligate those separately too. Then dissect the SSV down a bit more and remove a segment.
Not full stripping usually.
Generally not, because of the high risk of sural nerve injury further down the calf. Then careful closure of the deeper layer to prevent hernias, skin closure. And finally, deal with any marked varicose veins on the calf via stab incisions, paying attention to any leaky perforators connected to them.
Right, so we've covered the main veins. What about just removing those visible, lumpy surface veins? Ambulatory phlebectomy.
Exactly. Treating the main saphenous reflux is key for the underlying pressure problem, but those surface varicosities often remain bothersome symptomatically and cosmetically.
Used to involve big cuts.
Historically, yes, leaving bigger scars. Now, the standard is ambulatory phlebectomy using tiny stab incisions, just 1 to 3 millimeters. Much better cosmetically.
Needs careful planning, though, and patience.
Definitely. Might need lots of tiny incisions, maybe over 20 sometimes. Marking while standing is crucial, as we said.
Anesthesia for this.
Often ideal for local anesthesia, either just around the vein or using the tumescent technique. Epinephrine in the local makes the skin pale, but usually doesn't hide the veins too much for removal.
But skip the epinephrine sometimes.
Yeah, in patients with certain conditions, diabetes, glaucoma, heart disease, hypertension, poor circulation, EPT might be risky. Can omit it, might get a bit more oozing, but manageable with pressure.
And how do you actually get the vein out through such a tiny hole?
Mueller popularized the technique. Small hooks, iris forceps, fine clamps. You hook or grasp the vein, bring a loop out through the incision,
Yeah.
clear away fat, clamp it twice, cut between the clamps, then gently tease out longer segments by pulling. Rolling the vein onto the clamp helps stop it breaking.
What if it breaks?
Just make another tiny incision nearby to retrieve the remaining piece. You want to get all the varicose segments. These are usually branches, so ligation isn't always essential if the main saphenous source is treated. But for big ones under pressure, tying them off with dissolvable sutures is wise.
And nearby perforators.
Ligate any leaky ones you can access. Closure is usually just steri strips, maybe a single buried stitch for a slightly larger cut.
What about timing? If someone's having main vein ablation, do you do the phlebectomy at the same time or later?
Good question. There are two schools of thought.
Okay.
Staging it, doing ablation first. Phlebectomy later proponents say ablation alone might be enough symptom relief, avoiding more procedures. Or reducing the main reflux might shrink the branches, making later phlebectomy easier or making them suitable for sclerotherapy. Plus, extensive phlebectomy takes time, so staging can be efficient. And there's that slight increased risk of clots, EA height, when doing both together with thermal ablation.
And the argument for doing it all at once.
Better initial blood flow improvement addresses the progressive nature of the disease, and patient convenience, one procedure, one recovery. Reviews suggest combined approach gives better short-term and similarly long-term outcomes. Some recent data even shows better improvement in vein scores with the combined approach, so it's often a judgment call.
Okay. What was that other technique? Transilluminated powered phlebectomy or Trivex? Sounds high-tech.
It was. Use tumescent fluid, a light source under the skin to see the veins, and a powered suction cutting device, kind of like liposuction, to remove them through fewer, slightly larger incisions.
Benefits.
Supposedly fewer cuts, shorter surgery time. Some studies showed fewer cuts, yes. But results on time savings were mixed, often only seen in very expensive cases.
Downsides.
Some studies reported more bruising, more pain, worse early quality of life compared to standard phlebectomy. Reviews noted the time saving often came at the cost of more bruising and pain. Enthusiasm waned, and it's not commonly used now. Patient satisfaction wasn't always great either.
Interesting. Now, what about these saphenous sparing operations? Sounds like a completely different philosophy.
It kind of is. Based on detailed ultrasound mapping, these challenge the traditional idea that the main saphenous vein is always the primary problem.
How so?
The old theory was reflux starts high up at the deep junctions, spreads down the saphenous, then outwards to branches. But some detailed mapping suggests maybe it starts lower down in the surface veins and ascends upwards.
The descending theory.
Right. So proponents of this only treat the truly incompetent segments, focusing on varicose branches and trying to preserve the main saphenous trunk if possible. Two main types, CHIVA and ASVAL.
Let's take CHIVA first. What's the approach?
CHIVA, it's a French acronym, basically means ambulatory conservative hemodynamic management, needs super detailed pre-op ultrasound mapping, identify reflux origin, entry points, Exit points back to the deep system.
And the goal.
Interrupt the abnormal pathways, restore normal superficial to deep flow via perforators during muscle relaxation. You ligate incompetent tributaries, remove the associated varicosities. Whether you ligate the main saphenous depends on valve function, high and low.
Results.
Some long-term studies suggest lower recurrence of varicose veins compared to traditional HLS. One large study claimed cure was twice as likely, but it had methodological criticisms. Another small study showed benefits for venous ulcer healing over just compression.
So why isn't it more common?
It seems effective at reducing recurrence, but it's complex, requires extensive mapping, specialized training, hasn't seen wide adoption despite better ultrasound now.
And AZEL. Ambulatory selective varices ablation.
Also relies on selective removal, but focuses primarily on removing the varicose vein clusters themselves through lots of tiny stab incisions, often using Mueller hooks, under local tumescent anesthesia.
Preserving the saphenous.
Generally, yes, if the reflex isn't originating there significantly. A large study reported good long-term results, especially for milder disease. Patients maintained saphenous competence, had low recurrence, good cosmetic outcomes over 5+ years.
But time-consuming.
Can be, with potentially 30+ small incisions, but seems effective and durable for selected patients with milder disease when done by experienced surgeons.
Okay, we've covered a lot of ground on techniques. Let's talk results. What was the historical gold standard again?
For decades, it was high ligation and stripping, HLS. That was the benchmark. And most of the older data supporting surgery for CVI comes from HLS studies.
But that's changed drastically.
Hugely. HLS use has plummeted. EVA, endovenous ablation using heat or other methods, has soared. And sclerotherapy often replaces phlebectomy for branches now.
The numbers show a massive shift.
Yeah, HLS down from maybe 155,000 a year in the US in '99 to under 30,000 by 2016. EVA went from basically zero to over 350,000 in that same time.
So is the evidence really strong that EVA is superior long-term? What do the head-to-head comparisons show?
Well, let's first compare surgery versus no surgery. The ESHAR trial looked at severe CVI, patients with ulcers. Surgery, mostly HLS, didn't speed up ulcer healing itself, but it significantly cut ulcer recurrence rates compared to just compression and exercise, almost halved it at 12 months. And that's likely underestimating the benefit because a chunk of patients assigned to surgery didn't actually have it, but were still counted in the results.
Interesting. What about less severe cases, just varicose veins?
Another key trial, Michaels et al., compared compression lifestyle changes to HLS plus phlebectomy for uncomplicated varicose veins. The surgery group had significantly better quality of life, better symptom relief, better anatomical results.
So surgery does add real benefit over just conservative care.
These big trials strongly support adding surgery, yes, for varicose veins caused by GSV reflux.
Okay. Now comparing EVA directly to ligation and stripping HLS for the GSV. What's the verdict there?
Lots of trials have done this, mostly comparing laser or radiofrequency EVA to HLS. Quality varies a bit.
What do they generally find?
Immediately after, EVA usually wins on quality of life. Less pain, quicker return to normal activities, work. Makes sense, it's less invasive initially.
Well, longer term.
By about a month, disease-specific scores are often similar. Some studies show no difference even at a month. Quality of life results long-term are mixed. Some favor EVA slightly, some find no difference.
What about complications or side effects? Pain.
EVA avoids the stripping trauma, so less bleeding, bruising generally. But inflammation in the treated vein after EVA, thrombophlebitis, can be quite painful, sometimes as bad as stripping pain. Pain med use is often lower after EVA, though.
And tumescent anesthesia helps both.
Yes, significantly reduces pain and bruising for both. One study using tumescent for both HLS and EVA found reflux elimination was equal, return to activity similar. HLS had more initial pain bruising, but overall pain med use was the same.
What about the big one, recurrence? Do veins come back more often with one or the other?
Looking at multiple trials together, there's no overall significant difference in varicose vein recurrence or needing repeat operations between EVA and HLS long-term. Recurrence does happen over time with both.
But the reason for recurrence might differ.
Seems so. Neovascularization, new vessel growth in the groin, is more common after HLS. Recanalization, the treated vein reopening, is more common after EVA.
Where does recurrence happen after EVA? Thigh, calf.
Both seem comparable sites. One 5-year study found laser EVA had better technical success, meaning the vein stayed closed more reliably than surgery.
How does foam sclerotherapy compare long-term?
A comparison study showed much higher rates of recanalization, recurrence, and reoperation with foam compared to EVA or surgery after 5 years.
And another 5-year comparison, of laser EVA versus HLS, both with phlebectomy.
That one showed more clinical recurrence after surgery than EVA. Both groups had lasting improvement in vein scores, but the EVA group score was slightly better at 5 years. Vein closure rates remained high for both.
Okay. What about results for surgery behind the knee, the SSV and popliteal fossa veins?
Historically, recurrence after open SSV surgery has been disappointingly high. One study found recurrent SSV reflux in over 60%,
Why so high?
often due to inadequate initial ligation leaving the trunk intact or a long stump near the popliteal vein. Less often, a leaky perforator nearby was missed.
And it's not always the SSV itself causing the recurrence.
Right. Those other veins in the fossa, like the gastrocnemius veins, are often implicated. One study found gastrocnemius vein incompetence in about a third of recurrent cases after SSV surgery.
So again, thorough pre-op ultrasound and treating all incompetent veins back there is key.
Absolutely critical. You have to identify and address everything contributing to the reflux.
How does EVA fare for the SSV compared to open surgery?
One trial found EVA was significantly better at eliminating SSV reflux, 96%, maybe 72%. Also, less post-op pain, faster return to function, less sensory disturbance. Quality of life and vein scores improved similarly in both groups.
So EVA looks good for SSV too.
The evidence supports it, yeah. Though concerns about nerve injury back there have maybe limited its uptake compared to GSV ablation.
But good open surgery still has a role.
Definitely. A study combining meticulous ultrasound mapping with aggressive open surgery to eliminate all reflux points in the fossa reported excellent results. No nerve injuries, clots, infections, or early recurrence. Vein scores improved significantly. Supports the idea that well-planned open surgery remains a strong option for complex popliteal fossa disease.
So it really sounds like mixing and matching, tailoring the approach is the way forward.
It absolutely is. The variety of techniques just proves no single method is best for everyone or every vein. Vein specialists routinely combine things, EVA, maybe some HLS, phlebectomy, sclerotherapy, sometimes even stenting further up.
Can you give an example?
Sure. One trial looked at patients with GSV reflux and branches. They all got high ligation, but then were randomized to either phlebectomy or foam sclerotherapy for the branches.
Yeah.
At 3 and 5 years, both branch treatments were equally effective. Interestingly, many in both groups needed some follow-up sclerotherapy later.
Another comparison, HLS with stripping versus HLS with foam.
Yeah, that found no difference in recurrence or vein scores at a year. But the stripping group took longer in surgery, longer recovery, cost more. The fact HLS keeps being used in these trials shows it still has value.
What about problems higher up, like iliac vein narrowing?
Growing interest there. Stenting helps the outflow blockage. But one study found that even after stenting for iliac compression, adding GSV ablation improved vein scores, pain, and ulcer healing more.
So treating the lower leg reflux still matters, even with outflow issues.
Seems so. That study used EVA, but likely HLS would offer similar benefits in that scenario.
What if veins come back after previous HLS? Recurrence in the groin.
Happens in up to 40% after 10 years sometimes. Often neovascularization or a long stump left behind. Treatment is usually repeat surgery to find and ligate or remove the reflux source. Results vary. Recurrence can still happen, maybe up to 20%.
Any tips for redo groin surgery?
Often, a lateral approach helps avoid the worst scar tissue. Need to expose the femoral vein clearly, ensure the connection to the deep system is fully dealt with. Some techniques involve dissecting recurrent veins off the femoral vein, maybe placing a patch as a barrier. Studies show good short-term results with meticulous technique.
Okay, it's clearly complex, and practicalities like insurance and reimbursement must play a role too.
Absolutely. Insurance companies have their rules. Medical review criteria usually need symptoms, ultrasound proof of significant reflux, and that trial of conservative care compression stockings, etc. for maybe 6 weeks to 6 months first.
Unless it's more severe.
Right. Ulcers, skin changes like lipodermatosclerosis, significant bleeding, recurrent clots, those often qualify for intervention more readily.
Do insurers care if it's EVA or HLS?
Generally not for authorization purposes or the setting, no. But how doctors and facilities get paid differs hugely.
How so?
Hospital or surgical center means a professional fee for the doc, facility fee for the place. Office procedure often means one global payment to the surgeon covering everything.
Which can make hospital procedures more costly overall, and maybe less profitable for the surgeon.
Often, yes. That, plus less invasive techniques and the rise of vein centers, has pushed a lot of vein work into the office setting.
What about cost comparisons, EVA versus HLS?
UK studies found ablation often more expensive initially due to equipment costs. But they argued quicker return to work might justify it. Overall, cost-effectiveness analyses are complex. One UK analysis over 5 years found conservative care most cost-effective for milder disease. HLS and EVA were acceptable options for more significant issues.
So finances are definitely part of the equation.
For sure. Insurance rules, cost-effectiveness data are always changing, influencing choices alongside clinical judgment and local realities.
Given that EVA is so dominant now, are there still clear reasons to choose traditional ligation and stripping for the great saphenous vein? Specific situations.
Yes, definitely. Even with EVA being favored, HLS still has important indications. Okay, one is a very superficial saphenous vein or tributary, really close to the skin. If you don't have, say, a centimeter of tissue buffer for the tumescent anesthesia, thermal ablation risks skin burns. Not advised.
And non-thermal ablation.
Avoids burns, but can still cause inflammation if it's right under the skin. So
Yeah.
for very superficial segments, HLS or just phlebectomy might be safer and better.
What else? Very large veins.
Yeah, if the GSV is really dilated, maybe over 2.5 or 3 centimeters wide, or has big bulging aneurysmal segments, those can be hard to ablate effectively, might thrombose more readily after ablation. LNS might be a better bet.
What about veins scarred from previous clots? Chronic thrombophlebitis.
Right, that scarring can block the ablation catheter. HLS with a stripper might still get through. If not, simple ligation and removing the affected segment works. Also, if the vein wall is super thick on ultrasound, it won't shrink well with thermal ablation. HLS is better.
Infected clots. Suppurative thrombophlebitis.
That's rare, thankfully. Antibiotics are key, but open surgical ligation and maybe partial stripping can be very helpful for stubborn cases. EVA is definitely out no role and has even been reported as a cause in rare cases.
Very twisty veins. Excessive tortuosity.
Similar problem to scarred veins, hard to navigate with a catheter. HLS might be more feasible.
What about acute clots extending near the deep system?
Acute superficial thrombosis reaching the SFJ that's mainly managed with anticoagulation now, but GSV ligation is sometimes still considered to prevent propagation. EVA is absolutely contraindicated in acutely thrombosed veins.
Many other special cases, like congenital issues.
Lateral marginal veins, sometimes seen in Klippel-Trenaunay syndrome. Big, problematic veins, high clot risk. EVA can be used, but open ligation and segmental removal is also very effective, especially for stubborn ones or after EVA complications. Might need tourniquets, staged procedures for those.
And finally, simple economics.
Yeah, can't ignore it. Setting up an endovascular program is expensive. Equipment costs $50 plus ongoing supply costs per case. Can be a good investment, but a barrier for some. And if patients are paying out of pocket, they might opt for less expensive open procedures if appropriate. So yes, HLS still has a distinct, important place.
This has been incredibly thorough, a real deep dive into surgical treatments for varicose veins. Let's just recap the main takeaways.
Sure. So we've seen there's a whole spectrum from traditional ligation and stripping to modern endovenous techniques for both main saphenous veins, plus phlebectomy for branches and ways to handle complex situations.
And the landscape is clearly evolving.
Absolutely. Endovenous is often first line now, but open surgery remains crucial in specific scenarios when it's carefully chosen.
Which brings us back to individualization.
Exactly. The best plan depends entirely on your specific anatomy shown on ultrasound, your symptoms, your health, your preferences. Really need that thorough evaluation and discussion with a vascular specialist.
A crucial point. Okay, final thought then. Given how common venous disease is and how techniques keep improving, what further innovations do you think are on the horizon? What's next for improving management and long-term outcomes for people with varicose veins and CVI? Definitely food for thought. Thank you so much for joining us for this deep dive.